Hey, how you doing? My name is Zach, PGY2 for those who do not know me. Today I'll be talking about um, evaluating pneumonia with ultrasound. Just a little outline. First, I'm going to just talk about the basics of just lung ultrasound. Um, in regards to that, it'll be like positioning, probe selection, and then overall tips of how to perform just a basic lung ultrasound. Then I'll be discussing the typical ultrasound features of pneumonia, and then just the use of ultrasound for pneumonia and disposition and just the accuracy in regards to ultrasound findings. So just an overview, in lung ultrasound, it's all based on the interpretation of artifacts produced at the pleural surface. Most of these relate to the way ultrasound and the air interact. Okay, this means that pathology that lies pretty deep to the air cannot really be visualized. So you just have to be cautious of that. But most ultrasound, most of the imaging we try to see is in regards to the pleural surface, with the exception of like the mediastinal reflections. To begin, you should have a proper positioning with the patient. Usually with trauma protocols, it mandates that the patient is supine. This is because most times you're trying to evaluate for pneumothorax, where the free pleural air gathers at the most like apical point of the thoracic cavity. Pneumothorax is a little different. I won't really go into much detail about that. Also, intubated patients generally, just because of how the situation is, they're usually managed supine as well. But for evaluation in ED, most of our patients are pretty conscious and aware. Some of them are a little critically ill, some of them are not, more stable. Those in acute distress, they usually sit up, they usually try to optimize their ventilation. You might see them, hunching over and so forth, while others are just sitting comfortably texting. Either the those in acute distress and those that are just comfortable, you can do simple maneuvers to help with your ultrasound. You can have them cross their arms, raise their arms up, just so you can move the scapula laterally when you want to evaluate posteriorly, or you can have them open up a little bit to evaluate the anterior lung fields. Next, you have to discuss like probe selection. On the left, you see there's a curvilinear. In the middle is a linear, and to the right is a phased array. Most of the times, you're going to use a curvilinear. It's a low frequency, about 1 to 5 megahertz. It gives good penetration, up to like about 22 centimeters, I believe. And the larger footprint allows for us to see a larger field of the pleural surface. This also helps when we want to evaluate the claustrophrenic angle. And placing the transducer in like the line of the intercostal space allows for like an extended view of the pleural surface as well. This is our go-to probe for most times. It's ideal when you want to search the pleural surface for pathology, and then we can also shift to the upper abdomen to explore like the diaphragmatic surface of the lung. Say you do find pathology and you want to see it in like a higher resolution, then you may switch to the linear. The linear probe is a higher frequency, about 3 to 12 megahertz. Only goes about like 4 or 5 centimeters. But these are the ones that you go to if you want to see something in high resolution, see something close to the pleural surface, or even if you want to evaluate the ribs or the sternum for fractures. You can use either one, the curvilinear or the linear, for infants and small children. The linear might be a little bit more ideal for evaluating children, just because they don't have as much body mass and you don't have to look as deep for other pathology. So that's why most times people might use a linear for small children. The phased array, we don't really use for lung evaluation, but you can. When we were first doing like early lung ultrasounds, it was actually from the ICU. People do the echoes and then quickly do an ultrasound. It's similar to the curvilinear, where it's low frequency. So you have good depth. You can go about like 25 centimeters, but the resolution is pretty subpar. Even if you're looking at the pleural surface, sometimes even within the several centimeters of the skin, you don't really get good assessment. But some people believe that with the small footprint, you can see like the smaller intercostal spaces a little bit easier. But on the flip side of that, because it's a small field, you might also miss a lot of pathology that might be missed. But in most cases, we're not using the phased array and identifying like lung pathology. We're going to go straight to the curvilinear. In terms of the overall technique, there's multiple, different zones. You're gonna basically look at the anterior, superior, anterior, inferior. You're gonna look at the lateral, superior, lateral, inferior, which I have outlined right here. I feel like most times when we're evaluating the lungs in the ED, we don't even look at the posterior, superior, inferior, but that's also, an option as well. And then these markings that I have out in the picture, it represents different zones. Oops, sorry. So the one, like you can see on the right, this is zone 1, this is zone 2, and this will be on the left side, and then on the right side would be zone 3 and zone 4. You have 4 zones, 6 zones, 8 zones, 12 zones, 14 zones. It gets pretty, substantial. And the whole reasoning behind that is that you want to evaluate the bilateral lobes, both the upper and lower lobes, anteriorly, axillary line wise, and also posterior. When you're evaluating the lung, you should look at the chest wall, look for the ribs and the intercostal muscles, ensure the orientation is appropriate. You want to, of course, look at the pleural line. First thing is to make sure there's lung sliding, hold the transducer pretty still, look for the movement of the pleural line. And then you want to evaluate for, different artifacts. You're going to look at the vertical artifacts and also the horizontal artifacts. The vertical artifacts could be like comet tails, B-lines, and then we'll discuss more what B-lines are and so forth. But if you do see those things, how many there are, if they're confluent, and you also have to, take into place, you have to take into consideration the clinical picture. Is it acute? Is it chronic? Does that, does it represent like fluid, fibrosis? The horizontal artifacts would be more like A-lines. And you have to see if those A-lines are interrupted by, B-lines or so forth. And then of course, you're gonna start anterior cranially, meaning, on the most anterior, and kind of like mowing the lawn, you go down and then you go to the axillary and then you go to the posterior and so forth. And you have to think about all the pathological non-aerated areas as well, which allow for like deeper penetration. These could be like pleural effusions, pulmonary consolidations, infarctions, even like a lung collapse or a lung tumor. And you have to determine where the abnormality lies, if it's in the pleural space, or if it's even in the actual lung, whether it's actually within the lung itself. But the whole purpose of my talk today is just to identify pneumonia and the signs of pneumonia on ultrasound. We all know the clinical signs of pneumonia. This is just a chest X-ray displaying a consolidation. Typically, the alveoli, and when you have pneumonia, is intensely inflamed, and you might have like areas that's filled with like liquid, fluid, or pus, and this is the consolidation that we see. It could be widespread, it could be patchy, it could be lobar. But overall, ultrasound can detect all these pulmonary changes as long as they involve like the outer, non-mediastinal pleural surface. In terms of the features of pneumonia, early pneumonia, you're gonna see like B-lines, you're gonna see subpleural consolidation. As it progresses, you might see lung hepatization. You might also see something called the Shred sign. And also you might see something called air bronchograms. I know there's a lot going on in this slide, but if you draw your attention to the first picture right here, this is just a normal, ultrasound. You see the pleural line, you see the horizontal artifacts, which are the A-lines. If you look below it and D, you see confluent B-lines. And these B-lines are just tiny areas of like, not tiny areas, I'm sorry, these are just artifacts where the fluid-filled alveoli are surrounded by like air-filled lungs. The B-lines are just like a sharp path like reverberation that occurs. If you look in B, you see right below this pleural line, you see these small subpleural consolidations. And then in an appropriate clinical setting, If you start seeing like patches of numerous B lines and often with little subpleural consolidations, you can, identify this as like early pneumonia. And here's just a video of the same findings. On the left, these are just the B lines. And then on the right, if you look right up top here, you see this area with the subpleural consolidations. And like I know nowadays with all this COVID time, we're quick to put the ultrasound on to evaluate for APE and so forth, but also evaluate COVID. You might have similar signs as well. You might see the scattered B lines with subpleural consolidations, but if you do an echo, you evaluate the EF, you look for like a non-plethoric IVC, you can prove that these B lines are not really pulmonary edema. There's other signs to go with COVID, but I'm not really going to discuss, but just take into consideration when you're actually scanning someone that, it could be like a COVID pneumonia and so forth. Another feature of pneumonia is lung hepatization. Pneumonia progresses through stages, and the ultrasound changes vary depending on the degree and extent of the consolidation. You're going to have like this inflammatory and purulent fluid filled the alveoli, and the lung appears solid with like a homogeneous, like fine equal texture, and it looks similar pretty much to a liver. Pathologists often cause this macroscopic changes, hepatization, and that's where we get the lung hepatization from. However, atelectasis also results in a solid non-aerated lung, and sometimes differentiating between the two can be a little different. But what you can use to identify that is air bronchograms, which I'll discuss later. But you have to take in consideration in pneumonia, the volume of the lung remains unchanged, or actually increases with air spaces filled with inflammatory liquid. While in atelectasis, the alveoli are like collapsed rather than fluid filled, so the lung volume may be reduced. Ultrasound overall helps to identify any cause of like atelectasis, or I should say most causes, like a large pleural effusion, but there could be some small subtle findings, like some scalloping of the pleural borders, and so forth. So here's just a live imaging of lung hepatization with the lung and the liver looking similar. A next feature of pneumonia is the Schreck sign. Basically, it's just the irregular junction between a consolidated and aerated lung. So if there's like a lobar consolidation, the borders of the consolidated areas would be linear and well-defined, while you go around the pleural surface, a little deeper, the borders usually demonstrate like an irregular surface with the underlying aerated lung. So basically just an irregular consolidation with like air interface. And if you look on the right, you can see the superficial border on the top, and then deep border with the shredded, the Schreck sign. And then here is just a live video displaying the Schreck sign. Lastly, another feature of pneumonia is air bronchograms. Air is within the consolidated area may remain in small aerated patches of lung, or more commonly, the air remains within the small bronchi. The echogenic appearance of like the small air bubbles all lined up with the bronchi are known as air bronchogram. So there's two different types. There's static versus dynamic air bronchograms. So if the bronchograms are mobile, meaning that they're continually moving with respiration, those are considered more dynamic air bronchograms, and this is pathognomonic for pneumonia. If the bronchograms are immobile, these are called static air bronchograms. They could also be seen in pneumonia and also atelectasis as well. Here is just some still imaging of some air bronchograms on the right. But overall, this just means there's no complete like bronchial obstruction, and infers that the solid lung is more likely due to a true consolidation rather than collapse of associated, reabsorption like atelectasis. But overall, with time, the air within those air bronchograms is going to be replaced with fluid, and those fluid-filled bronchi might, branch out to like a hypoechoic like appearance with relatively like echogenic walls. Here's an example of a dynamic air bronchogram, and if you look, you can see how the bronchograms is mobile. And then, I don't know, can you guys still see this? Hopefully, I didn't ruin it. But just to give you a better, clearer picture of like the static versus dynamic, if you look on the left, you see the air bronchograms where the arrows are pointed, they're not really moving. But if you look on the right, you see how the dynamic, how it's kind of mobile and it's moving back and forth. That's a pathognomonic for pneumonia. That's a dynamic air bronchogram. I think everyone, 1 second. Okay, so moving forward, those were the clinical, I'm sorry, the ultrasound findings for pneumonia. Doing like some review of just some, papers. Guidelines don't really suggest that, ultrasound is, an alternative to chest X-ray or CT for diagnosis of pneumonia as of right now. But like a systematic review of about like 20 different studies with like about 2,500 patients throughout both adults and peds in the ED, the wards, and ICU. Showed a sensitivity of 85% and a specificity of 93%. In terms of like ultrasound findings, they were looking at hepatization, shred sign, and air bronchograms. The gold standard was, of course, using CT, chest X-rays, and also clinical diagnosis and identifying pneumonia. But the one large caveat with this, with most of the findings in the study, was that it had a very large degree of heterogeneity. A large amount of the ultrasound examinations were between like ED docs, intensivists, radiologists, all the varying like levels of expertise. And the patients range from ambulatory to critically ill. Meanwhile, like another systematic review with about 17 different studies, about 5,000 different patients with similar gold standard with chest X-ray, CT, and like clinical findings. But this time, in identifying using ultrasound to identify pneumonia, they look specifically for subpleural consolidations and or like focal B lines. And another difference with this is that the proponents or the operators of the ultrasound examination were mostly just ED docs or radiologists. And here you see the sensitivity rose to a higher amount to 92, and the specificity is around the same at 94%. And if you look at both, the likelihood ratio, bringing it back to step one, which is basically the likelihood ratio basically tells you how likely a patient is to have the disease or not to have the disease. The higher the ratio, the more likely they are. Conversely, like a low ratio is likely they do not. If it's 1, it's pretty much not non-substantial, but if you raise it up to like 10, it's like a 10-fold. So the positive likelihood ratio for both was 12.14 and then 15.3. It pretty much says that it's specific and you can rule in the disease. Meanwhile, if it's less than 0.1, it's great to say that it's sensitive to rule out the disease. So it shows overall that lung ultrasound is very specific and sensitive when it comes to pneumonia. I even saw another study that did a meta-analysis that supports that when conducted by highly skilled sonographers, they don't really identify what highly skilled is per se. That's the only drawback. It does perform well for the diagnosis of pneumonia. In this study, in this meta-analysis, they did about 10 studies with about like 1,200 patients. And they showed that the sensitivity and specificity was about 94% and 96%. Similar with all the rest of the studies, chest X-ray and CT scan were the gold standard. And they primarily looked at just adults greater than 18. What was different from this study with the rest is that all diagnoses had to have a chest X-ray and chest CT scan at the time of evaluation. And they noticed that they also timed the lung ultrasounds, and they said it took a maximum of 13 minutes to conduct. I know we've all been in the pods and we're waiting for chest X-rays and CT scans. So, within 13 minutes, you can have a diagnosis and be able to say, okay, you have pneumonia, discharge, and have your antibiotics. So, in summary, when doing a lung ultrasound, you have to be aware of positioning. You have to make sure you choose the right probe, and you have to have proper technique. I know oftentimes we just do anterior, but oftentimes we should, evaluate the lateral aspects and also the posterior just to have complete, image of what's going on in the lungs. And if we're discussing pneumonia, you should also, look for B lines and subfluid consolidation, but also taking into, consideration, the clinical picture, if it's fluid overload patient and so forth. You also got to identify lung patternization, shred sign, and of course, air bronchograms, whether it's static or dynamic. These are my references. Any questions?
May I have a comment? Hello?
Mark's 13 minutes, that's too many patients.
Yes, go ahead,
yes, Dr. Z, we can hear you.
Okay, the point that I want to make is all the information or most of the literature that is published about ultrasound for pneumonia, actually there's really no good gold standard for pneumonia. So the focus of the ultrasound is, and all the sensitivity and the specificity and other diagnostic characteristics that you presented, they are for identifying consolidation. So it is safer to say, to look at the diagnostic characteristics of ultrasound and identifying a consolidation. Pneumonia mostly is a clinical diagnosis, and a consolidation can be pneumonia, can be atelectasis, can be a mass. So this is the limitation of all the studies done on ultrasound for pneumonia. They are actually identifying a consolidation. Whether that consolidation is pneumonia or not, that's a separate issue.
Dr. Z, can the same be said about chest X-rays? Because we always get the imaging and then we combine that with the clinical picture of the patient, because as you said, there's no real good test to diagnose, no good imaging test as to diagnose pneumonia for us, correct?
That is correct. So there's really no good gold standard for pneumonia, whether it's such, and that limits any test that is trying to identify pneumonia. That will be a limitation of that test, whether this is a chest X-ray, whether this is a CT. How many times you have seen a chest X-ray that the radiologists read as could be atelectasis, could be this, could be that, right? Clinical correlation indicated. This is the same case. Pneumonia is a diagnosis of, it's a clinical diagnosis. So ultrasound, chest X-ray, CT, they identify consolidation, not pneumonia.
This is Rich Center. The other issue with most of the ultrasound research that's published is they never do inter-rater reliability. And I think this is very important to see if the reproducible operator and reader can identify the same thing on the same ultrasound repeatedly. So I think that this is a big problem with the ultrasound literature.
Zach, do you happen to know in the studies that you cited, do you happen to know if they talked about inter-rater reliability, like if two providers do the same scan, did they get the same results?
Not really per se, no.
We need a 4-hour conference to discuss limitations of ultrasound studies. No offense to our ultrasound colleagues.
None taken.